Welcome to StudyNeuro. In this lecture, we will focus on the principles of surgical management of cerebrospinal fluid rhinorrhea, with particular emphasis on endoscopic repair, skull base reconstruction, and the management of complex defects. The central theme is straightforward. Successful repair depends on understanding the defect, choosing the appropriate surgical corridor, and constructing a reconstruction that remains durable under cerebrospinal fluid dynamics. By the end of this lecture, the goal is to understand how surgeons approach cerebrospinal fluid leak repair as a decision-making problem rather than simply a technical procedure. We will consider the anatomical and physiological factors that influence approach selection, compare endoscopic and intracranial strategies, and review reconstruction options. We will also look at why repairs fail and how recurrence should be investigated. Most importantly, the aim is to develop a practical framework that can be applied to individual patients.
Cerebrospinal fluid rhinorrhea occurs when there is an abnormal connection between the subarachnoid space and the sinonasal tract. The danger is not simply the nasal drainage itself. The persistent communication compromises the normal separation between the intracranial and sinonasal compartments. Surgery, therefore, has several objectives: eliminate that pathway, rebuild the skull base barrier, and preserve surrounding neurological and sinonasal structures. For many well-localized anterior skull base defects, endoscopic endonasal repair provides the least invasive, effective route. The reconstruction must ultimately withstand the patient's cerebrospinal fluid dynamics. Not every patient with cerebrospinal fluid rhinorrhea requires immediate surgery, so the indication needs to be considered in context. Persistent or recurrent leakage, a high-flow leak, a substantial skull base defect, or an associated meningocele makes definitive repair more compelling. Surgery also becomes important when conservative treatment has failed or when the leak has resulted in complications such as meningitis. The situation is different when there is significant trauma, progressive pneumocephalus, or intracranial pathology requiring treatment. The presence of rhinorrhea alone does not determine the operation.
Planning begins by confirming that the nasal drainage is truly CSF, using beta-2 transferrin or beta-trace protein when needed. Imaging then defines the defect. Thin-cut CT provides the bony roadmap, while MRI identifies herniated tissue and associated intracranial abnormalities. When routine imaging cannot localize the leak, targeted cysternographic or dynamic techniques can provide additional detail. The surgical approach is determined by the defect and the surrounding anatomy. The key considerations are accessibility, defect complexity, CSF flow, encephalocele, prior surgery, and any associated intracranial pathology. Endoscopic endonasal repair is preferred when adequate exposure is achievable, with reported success around 90%. An intracranial or combined approach is reserved for defects that cannot be adequately accessed or when additional intracranial treatment is required. Once the defect is fully exposed, the key is to create a clean, vascularized surface for reconstruction while safely managing any herniated tissue. The choice of repair depends primarily on defect size and CSF flow. Small, low-flow defects can often be closed simply, while larger or high-flow defects require stronger, multi-layer reconstruction and structural support. The final repair is stabilized, with lumbar drainage reserved for selected high-risk cases. There is no single reconstruction material that is appropriate for every cerebrospinal fluid leak. Surgeons may use autologous tissues such as fascia, pericranium, septal tissue, muscle, or fat, while selected dural substitutes can also be incorporated. Vascularized tissue, particularly a pedicled nasal septal flap, provides additional biological reinforcement when appropriate. Larger defects may also require structural support with bone or cartilage. Fibrin sealant and reinforcer repair, but it should remain an adjunct rather than the primary method of closure. Mechanical stability comes first, sealant is secondary. The reconstruction can be designed in several ways depending on the anatomy. With an inlay or underlay repair, the graft is positioned beneath or within the defect and supported by the surrounding skull base. An onlay or overlay places the graft over the defect and extends beyond its margins. For larger or higher flow defects, several layers may be combined so that each component contributes something different, such as structural support or tissue integration. A multi-layer reconstruction might therefore combine structural material, a fascial graft, and vascularized tissue. The repair should match the demands of the defect. This figure summarizes how skull base reconstruction is tailored to the location and characteristics of the defect. Small cellar or supracellar defects may require an inlay graft, fat, or vascularized flap, depending on the leak and diaphragmatic anatomy. Larger anterior cranial fossa defects often require multi-layer reconstruction with a vascularized flap. Posterior defects similarly require site-specific grafting and vascularized tissue. The principle is simple. Match the reconstruction to the defect, rather than using one technique for every leak. The principles guiding encephalocele and meningocele repair begin with preservation. First, determine what tissue is viable and functional, and protect it from unnecessary manipulation. Next, identify and avoid critical neurovascular structures. Only clearly non-functional tissue should be considered for reduction or resection. The final goal is durable separation of the intracranial and extracranial compartments through secure dural and bony reconstruction. The intracranial approach is considered when endoscopic access does not provide sufficient visualization or control of the defect. It is particularly useful when there is major brain herniation, extensive anterior cranial fossa disruption, or associated intracranial pathology that requires direct treatment. However, the wider exposure comes with greater morbidity, so the approach should be chosen when the benefits of direct intracranial access clearly outweigh the risks. The choice of craniotomy should follow the anatomy of the defect rather than a fixed approach. Central defects may require frontal or subfrontal exposure, while more lateral or middle skull-based defects may be better approached through frontotemporal or temporal-based routes. Once inside, the sequence is deliberate. Address any urgent intracranial pathology, define the defect, clear unstable bone, and manage herniated tissue. The reconstruction then restores the dura and bony skull base, with vascularized tissue reinforcement to provide durable healing. The choice between endoscopic endonasal and intracranial repair depends mainly on defect accessibility and complexity. Endoscopic repair provides direct transnasal access to many anterior skull-base leaks, usually without brain retraction and with lower approach-related morbidity. Intracranial repair offers broader exposure for selected complex or inaccessible defects, but may require brain retraction and carries greater craniotomy-related morbidity. Reconstruction ranges from multilayer grafts and vascularized flaps to dural, pericranial, and structural repair. Combined approaches are considered when the skull base injury extends across regions that are difficult to manage safely from a single direction. In these situations, the transcranial route can provide control of the intracranial surface and associated pathology, while the endoscopic endonasal route offers direct access to deeper or more anterior skull base defects. The approaches are complementary, not repetitive. The objective is to bring these advantages together to achieve complete visualization, secure reconstruction, and durable separation of the intracranial and sinonasal compartments. The strength of a combined strategy is that each approach contributes something different. The transcranial route offers broad intracranial visualization, control of the anterior skull base, and access for intracranial pathology and pericranial flap reconstruction. The endonasal route provides direct access to the sinonasal corridors and deeper regions such as the sella and paracellar skull base, with vascularized flap options for reconstruction. The approaches are complementary, not duplicative, and should be used according to the anatomy of each defect. The combined repair is performed in a coordinated sequence, with each approach addressing the areas it can best control. From above, the dura is prepared and supported with an inlay graft, while the pericranial flap is extended along the skull base to cover the frontal and anterior defects and, when possible, reach toward the paracellar region. The endonasal component then provides direct visualization from below, allowing the deeper defect to be exposed and prepared. An important advantage is the ability to inspect the reconstruction from both sides and confirm that the entire skull base barrier is secure.
Cerebral spinal fluid dynamics become particularly important when the leak is spontaneous. An underlying pressure disorder may contribute to skull base remodeling, formation of meningocele or encephalocele, and eventual recurrence after repair. This is why simply closing the visible defect may not address the entire problem. Lumbar drainage can be considered selectively in situations such as high-flow leaks, complex repairs, difficult revisions, or selected persistent postoperative leaks, but it is not necessary for every patient. A durable repair requires attention to the forces acting on that repair. Even technically well-performed repairs can fail. Recurrence may present as persistent cerebral spinal fluid drainage, and complications can include meningitis, pneumocephalus, hemorrhage, olfactory dysfunction, or sinonasal problems. When a repair fails, the surgeon should look beyond the graft itself. Was the original defect accurately localized? Was exposure adequate? Was the reconstruction sufficiently robust? Were multiple defects or a complex encephalocele overlooked? Was clinically important intracranial hypertension left untreated? Recurrence should trigger reassessment, not simply repetition of the same repair. A practical way to approach these patients is to move through the problem sequentially. First, confirm that the fluid is cerebrospinal fluid. Then, localize the fistula and characterize its location, size, flow, associated encephalocele, and underlying cause. Next, consider the cerebrospinal fluid pressure environment. An accessible anterior skull base defect will usually favor an endoscopic endonasal repair, whereas an inaccessible or complex defect may require an intracranial or combined approach. Reconstruction is then tailored to the defect, followed by protection, surveillance, and attention to factors that could drive recurrence. In conclusion, accurate localization remains the starting point for successful surgery, and endoscopic endonasal repair is preferred for many accessible anterior skull base leaks. Larger or higher flow defects may require more robust multi-layer reconstruction and vascularized tissue. Intracranial approaches remain useful, but mainly for selected complex situations where endoscopic access or reconstruction is inadequate. When a leak recurs, reassess both the anatomical repair and the cerebrospinal fluid dynamics. The ultimate goal is durable closure without sacrificing neurological or sinonasal function. Thank you for joining StudyNeuro for this lecture. If you found it useful, like, comment, share, and subscribe for more high-yield neuroscience and clinical education.